The GRID study was a randomized phase 3 study looking at patients who had gastrointestinal stromal tumor that was unresectable. And these patients were also very heavily pretreated in that they had progressed through imatinib as well as another agent, sunitinib, and up to 20% of them had also received additional therapy on top of those two regimens. This was a randomized study, again randomized patients 2 to 1 to receive either regorafenib or placebo. And the primary endpoint of this study was progression-free survival. The patients who did receive regorafenib had a progression-free survival of about 4.9 months versus 0.9 months in patients who had received the placebo. At the ESMO meeting, they discussed continuing patients on once they were unblinded because these patients were allowed to cross over. The patients that had been on placebo then crossed over and received the regorafenib had a median progression-free survival of 5 months, suggesting that they continued to benefit it. And then some patients who were unblinded but progressed upon receiving the regorafenib were unblinded and then continued to receive this drug. And I think that that's the question that you're asking is, what is the value of that? And I think that what we need to do is look at the biology of the tumor itself to determine whether or not patients will receive benefit. First off, the study was looked at with investigator criteria, and so you have to take that with a little bit of a caveat that the investigators made that decision and it was not a central review. But I also think that the population, the tumor cell population, may be very heterogeneous, and so that some of those tumor cells were still responding, and indeed we have seen in prior studies that when cytostatic agents are taken away, sometimes the tumor grows very rapidly. So I think that if patients don't have the availability of enrolling in another clinical trial, continuing an agent beyond progression is not always an unreasonable option.